talking about the posterior segment today. Like everyone's talk about the anterior segment, so I think it's the time for posterior segment now. I introduce myself as Sanjita Sarma, and I'm working as retinal surgeon in Nepal at Telganga Institute of Ophthalmology. I have no conflict of interest for this presentation. It is the turn as we examine the patient to understand the preoperative consideration as we examine the patient. So the status, the factors that we think as a retinal surgeon to look forward into before going or planning for a retinal surgery for diabetic vitrectomy is the status of the lens, whether the lens is clear or it is with cataract. If there is any need of preoperative intravitreal anti-VEGF or steroid injection, and the status of the retina, whether there is only tractional retinal detachment, whether it's just the vitreous hemorrhage that is present with the diabetic retinopathy, or it is the combined retinal detachment. This is one of the, I think, one of the important slides among the slides that I have, because this gives the planning for a surgeon to equip oneself for a better surgery. The role of anti-VEGF, as I said, is pre, intra, and post-operatively helpful. But we have to be cautious with its use in patients with severe systemic compromise diabetic patient, because as we know that once we inject the anti-VEGFs, we have to prepare the patient for surgery within a week. If there are certain conditions where the patient's general health is compromised and we need to hold the surgery for beyond 1 week of injection, then we need to think twice or even thrice and think and say whether we are going to plan for intravitreal VEGF or not, because we will be worsening and giving the crunch syndrome to the patient's vitreous and the retina and doing more of a damage. So timing, and so the previous slide which is preoperative consideration, this is a very important point. And like I said, if given 1 week prior, I preferably give within 3 to 5 days before the surgery. So within 1 week, there is less chance of crunch syndrome, and the proliferative vessels are occluded. Intraoperative bleeding is significantly reduced. It clears vitreous hemorrhage to a certain amount. If given in cases with fractional retinal detachment, there is no significant progress if within 1 week. This is the OS4 that we have been using in our institute, and I use it personally. And this has different parameters for the vitrectomy and the cataract, which has been explained by Dr. Budi. So I will be discussing about this a little later. Coming to the cataract and retina surgery for a diabetic patient with the status of the lens being not clear, for a surgeon like me, where we have to deal with the anterior segment cataract surgery and the posterior retina segment surgery, I think OS4 has been a very good, instrument, the machine where we get to have the benefits of the speed pump for the cataract, like Dr. Budi said, where there is a very good control of the anterior chamber and good control with the holding of the nucleus. There is no turbulence with the small particles of the nucleus. The importance of all of this as a cataract, for a retina surgeon from the cataract point of view, is the clarity that we need for a retina surgery after the cataract surgery. So the implementation of speed pump, where both the venturi pump and the peristaltic pump work together with good stability of the anterior chamber, has become a boon for doing a cataract surgery in a retina patient. So the options that we have for cataract surgery in diabetic patient is we go either for combined operation in a single procedure, or cataract surgery followed by vitrectomy surgery as a second stage surgery. When we plan for a cataract extraction followed by vitrectomy and lens implantation, it can either be implantation of the lens after we complete the cataract surgery and continue with the vitrectomy, or implantation of the lens at the end of the surgery after we complete the vitrectomy. The benefits of doing cataract surgery in a retina patient with significant amount of cataract is the better intraoperative access to the vitreous base, and enhanced stability with Oertli fluidics based on the physics. And it also gives a better option for a surgeon where we use the tamponading agent like the gas or silicone oil, where there is progression of the cataract at a faster and a speeder level. The operative principles of PDR vitrectomy is like dealing with the vitreous, releasing the traction, and flattening the retina, because that is where the pathology lies. We have to clear the vitreous hemorrhage. The clearing of the vitreous hemorrhage is very important, because there is a lot of issue of visibility with dense vitreous hemorrhage. So with the dynamics of the SPIP pump, here again, it is very helpful because we have a very good control of the flow, the cut, and the preciseness of the cutting that we get with the finer instrument with 27 gauge, 25 gauge, or 23 gauge vitrectomy cutter is influential in this stage. Whenever there is a very poor view with the vitreous hemorrhage, we just need to be calm, stay at a place where it is the safest, either on the nasal side or on the superior aspect of the retina, and just be good with the SPIP pump use of the vitrectomy cutter. Then coming to the release of traction, the traction is like anterior-posterior. There is anterior-posterior dissection of fibrovascular proliferation that we need to do, but we need to be very careful doing and conducting the PVD, because we do not want an uneventful thing happening like formation of the hole, because we have to be very thoughtful that the underlying retina is already very thin. There are already cystic changes. There's edema going on for a very long time. So the pull should be very less. The various techniques that we use are segmentation, delamination, en-bloc dissection, and ILM peel to release the tangential traction. So for this, I'd like to say that the finer instrument that we have with the good valved trocars, where the intraocular pressure is maintained to what we need, and with the finer tips like 25 or 27, even with the 23, the segmentation becomes very easy, because it is easier to find the planes where there are multiple traction. We just need to see where we can find a plane free of retina, where there is traction and the retina. We just need to go inside and do the segmentation. And this is very, very helpful with the finer cutter tips that we have with Oertli. The challenges in diabetic vitrectomy is, like I have already mentioned, the visibility, which is because of the cataract and the vitreous hemorrhage. The status of the posterior vitreous, like we discussed in the pathology of the vitreous body, it can be thickened, taut, posterior hyaloid. There can be dense and no separation of the posterior hyaloid from the retina. The fibrovascular proliferation itself is a very big challenge, because it can be very thick and broad. It is diffusely spread and covering the posterior pole. Multiple tented focal adhesions with vascularized bands, which gives a lot of bleeding when doing the surgery if not treated right at time. The status of the underlying retina is there are multi-directional traction with thinned out retina and cystic perifoveal region because of the edema. There is lack of differentiation of the tissue plane and intraoperative bleeders. With all the challenges, we have to overcome it, and the overcoming the challenges is with the instrument that is provided with the advancement in the instrument, which has been a tremendous amount of improvement, and the valve trocar, which gives a very fine cut to the sclera. The healing of the wound is easy. The valve gives a balance in the intraocular content, whatever is inside, because there is the control inflow and outflow from the valve. The post-op wound tightness is excellent, where we do not need the sutures. The ultra high cutting rates with the cutters that we have by the dual cutting, we can go up to 10,000, where the cutting is very fine, and we are very sure of what we are cutting, because we are using the SPIP pump, where we can control the flow rate and not have a very undulant and moving retina. Instead, we have a very balanced and a safe retina with the cut rates that we have, and the flow and the precise cut that we have. So apart from the SPIP pump, the easy access to change into venturi or a peristaltic pump, if in case of a need, is a boon because it has a very smooth transition from SPEEP pump to the venturi or to the peristaltic pump. The cutting close to the retina is possible, as I said, because of very fine cutters where we have the opening of the cutters very close to the tip, and we really can go to the very close to the retina and cut the tractional bands, making a very less use of the scissors or the forceps, where pulling there is always a risk of pulling the retina with the scissors or the forceps. So hence there is reduced risk of retinal tear formation, especially when used in conjunction with the low vacuum settings. And we always have an option of the hybrid system where we use high cut rates and low flow rates, where we use larger infusion size, but the two of the upper ports where we use for the light pipes and the instrumentation is finer ones. So this is the OS4 that we've been using. It has got the SPEEP pump, the flow rate, gravity dependent infusion heights, and these are the trocars which are very fine. It gives a very precise cut, and the wound tightness is, we do not need to apply the sutures. And these are the bent laser pipes, which come with the Oertli, and the benefit of having the bent laser is being in an institute where we train the doctors in fellowship or during their program of training. This is very safe as we can reach to the periphery without injuring the lenses. The other challenge that comes with the retina surgery, especially in the proliferative diabetic vitrectomy, is the intraoperative bleeding, which we have to manage with the hemostasis. The various parameters that we can apply for the hemostasis is increase in the intraocular pressure, endodiathermy, endolaser, mechanical tamponade using vitreous cutter or knob spatula, especially if it is like if there is a bleeding around the posterior pole, it is relatively difficult to control where we can do it with mechanical tamponade with the vitreous cutter. The adrenaline in the infusion bottle helps a lot, and fluid exchange is an alternative. So the other advancement that is there for bimanual vitrectomy surgery, where the surgeon has both the hands free for cutting what he or she needs to cut. It's having a third hand as a helper from yourself, because we have light source here, which is we insert in the 25 gauge, and then we do the surgery. Here is the chandelier light source, and we do the vitrectomy from here, where both the hands are free to cut. So I'm just trying to show how easy it is to insert the trocars with the Oertli here, and after this, so this is a very advanced case of diabetic vitrectomy where there is extensive fibrovascular proliferation, and you can see how easily I have been able to go very close to the retina. Because there was a very broad base retina, I needed to find a plane to go inside and cut it. So I've been using the forceps in between. But the cutters with the SPEEP pump, we can really move very close to the retina. There is a precise cut. It gives the confidence in the surgery to give a better outcome. So to conclude, surgery for diabetic vitrectomy still remains challenging. Improved surgical instrumentation has given an advancement to the approach to the surgery and its outcome, that is for sure. But careful preoperative, operative planning, including the choice of instruments, size of cutter gauge, and tamponade is the key for successful surgery. Anatomical success with meaningful visual rehabilitation, even in advanced cases, has become a regular part of diabetic vitrectomy, with improvement in instrumentation and the viewing system. With the mechanics, the fluidics that we play in the machine is a boon for us. The surgical pearls that I would like to say is we have to decide on the timing of surgery, the planning of the vitrectomy, looking at the type of eye and the affection it has, whether we want to go for bimanual surgery or it is just a regular vitrectomy. The key steps are core vitrectomy, truncation, finding the plane for surgical approach, relieving the traction, finding the multidirection it has, segmentation, en bloc dissection, and combine. So I think these are, I have discussed it already, and
Thank you, Dr. Sharma, for the comprehensive talk on the diabetic vitrectomy. How do you feel? What's the difference between the speed pump and a routine venturi pump for your diabetic vitrectomy cases? Well, obviously, you have a very extensive type of diabetic retinopathy in Nepal. So, how does that benefit you using the speed pump compared to usual
so
venturi pumps?
it is the preciseness and the closeness to the retina that we can go with the speed pump, where the retina is not very fluctuant. With the flow rate, with the minimal flow rate and a very high cut rate, even with the combined retinal detachment in diabetic vitrectomy, because of not having a very fluctuant vacuum there, the retina is very stable, and we can really go close to the retina, cut the membrane, and relieve it from traction.
So it's kind of like dissociating flow against vacuum, right? So basically, your vacuum should be high, but your flow is not high.
Yeah, flow should be low and vacuum should be high, right?
Yeah. So I guess that's why it explains the stability in the chamber for the cataract surgery part. Thank you very much, Dr. Sharma.
Thank you.
So I would like to show my experience with Oertli OS4 speed pump cataract platform. Before I start, I want to let me know what is the need of the cataract surgery to have the safe surgery and good result. There is a 4 item. The first is the anterior dip is stable and quiet dip, and then the good followability and good holdability for the nucleus, and then how is the efficiency of the energy to do emulsification to the nucleus. And now in Oertli, we have 3 platform here: cataract surgery platform, and then glaucoma surgery platform, and vitreous surgery platform. And the characteristic in peristaltic pump in the Oertli OS4 is can control and precise for the anterior chamber, and then high holding force without turbulence, so the less turbulent or not turbulent, and then little bit delay for rise, and then highly precise maneuvering with instrument deep into the chamber. And then the application can use the aspiration of the cortex and shaping of the filters in the periphery. Characteristic for the venturi pump here is can direct control, permanent aspiration, logic response, linear control of the suction power, and relation vacuum and flow is 10:1. So it can be application for the Inveco is strong followability and vitrectomy in core vitrectomy. The characteristic of speed pump is highly controlled and precise in anterior chamber, and then strong holdability without turbulence, very precise maneuvering with instrument when we have the deep anterior chamber. So summary for the summary speed pump is preset flow control in the machine, and then linear vacuum control under occlusion, and then high holding force with little turbulence, less delay than peristaltic, efficiency control, and vacuum only under occlusion. Summary for the 3 pump here, peristaltic, venturi, and speed. In peristaltic, we have the flow is direct, linear via pedal, and then the vacuum is indirect when they have occlusion, and then the advantage is low turbulence. And then in venturi pump, the flow is indirect, 10.1 via vacuum if compared with flow. The vacuum is direct, linear via pedal. The advantage is high speed. And then in speed pump, there is direct for flow is direct preset on the machine. And then vacuum, direct linear via pedal. The advantage of the speed pump is little turbulence and high speed. Let me see here, the grade of cataract is 3/4 grade. And when we do emulsification, let's see the tip is hold the ability very good, and then the anterior chamber very deep. When I do with the OS4, never have the shut of the anterior chamber. And then the followability is very nice. So that's like a magnetic for the nucleus touch to the vacuum tip. So easily to vacuum the nucleus. And then the energy is very effective. And then when do IA, I with bimanual. It's very safe because the anterior chamber is very deep and controlled by the speed pump. The nucleus can move to the tip, and then this called the good followability and holdability is very good for the nucleus. And then it's very safe. It's very hard to when we do chop for the nucleus. And then if the anterior chamber is deep, so when occlusion break, it's very nice because if occlusion break the anterior chamber is deep, it's safe for the surgery. This is my experience in surgery with OS4. The speed pump here is combined peristaltic and vacuum that for me is very confident to do if we have the hard cataract because the system is very safe, very stable, and then nice for the post-op surgery because the cornea is still clear for one day post-op. Thank you very much for the attention.
Do you attribute a speed pump for the clarity of the cornea because of the maintenance of the AC depth and high holdability to the nucleus? Is it that what is causing the cornea clear the post-op day?
Yeah, because with the speed pump, the turbulence is very low. Cornea is endothelium is lit with safety for the surgery. So after surgery, we have the clear cornea after, especially for the hard cataract is still good.
And what would be the vacuum for the dense cataracts?
Yeah,
that you use
my
speed
setting
pump?
is in flow rate is as usual 35, and then the vacuum is 500.
Actually, when I looked at the videos, the chamber looked very stable. It's not like there's no turbulence. It looks quite interesting. So is it completely attributed to the pump, or is it the infusion? There's some compensation to prevent post-occlusion surge, or it's just, do you think it's the speed pump that's helping you with reduced turbulence and stability? Yeah.
Yeah, yeah. In my surgery, that there is bubble, there is no move of the bubble, so it shows that the low turbulence or not turbulent when phacoemulsification for the nucleus. In my surgery, only one setting, the first until finish. As usual, flow rate is 35, and then the vacuum is as usual 500, and then the power is 30 or 40. No need to change again this settings in speed pump.
It is quite interesting because the settings are similar to a lot of peristaltic machines, and yet we don't see that turbulence that we see in peristaltic machines. So that is interesting. Yeah.
Yeah, agree.
Thank you, Dr. Budi.
The experience is very good because I had been using from other companies, and so change in the system, I thought that it would be a little different from what I was doing. But from the very first day, it was very good. So it was very smooth, and giving the good efficiency was the best of OS4 with me.
Like in 5 years, I told you, not even a single time I had to call for maintenance. Performance is great. We can go very close to retina. I've been doing 25 gauge with it. I haven't used 27 yet. With 25 gauge also, we can walk very close to retina. No such pull of retinal pull and all. It's very good.
I've been practicing as ophthalmologist since 2008, and I've been using Oertli since 2013 maybe. I have cataract 3 and OS 3. For me, basically for phaco, it's the same. It's brilliant machine. It's tough. It's just the machine that you can handle. You can count on. It's just never broken. And in my country specifically, we have problems with electricity. Other machine have problem with it, but Oertli doesn't have. If you imagine that you do surgery and the lights went off and it takes 5 minutes to turn back again, So it would be a stressful time for us. So just with the cataract 3, it just take 30 seconds. Turn it on, then you go.
OS4, the best thing is that it is fast and it is very convenient and easy to use. And OS4, there's no wire. Okay, so there's no it's no messes there. It's so clean and tidy. It's my favorite one, the laser, the inbuilt laser, right? So you don't have to ask your assistant to this thing. So this is easy going. So this looks like you're working at home, doing good thing.
The way that I'm dealing with the cataract, requiring a lot of holding power. With the ability to hold so well, I'm able to do the cataract in a more efficient way and much faster operating time.
It's small but compact and it's portable. Vacuum power is good and it was able to hold even a very hard cataract, and good phaco powers. I was able to do a case in no time.
So at Oertli, we have a big ecosystems. So staying up to date means we have close connections to universities or other partnerships.
Unpredictability of vitrectomy, OS4 gives the possibility to be ready for any certain situation, to make the surgery safer, easier and more efficient, to give the surgeon and patient the reliability for the better outcome for the patient.
OS4 has given me the opportunity of reducing my use of forceps. It has given me a very good result in terms of anatomical and the functional outcome of the patient with the OS4 in diabetics. The speed pump gives the advantage of both the venturi and peristalsis, so you are more confident in going close to the retina, giving the best judgment to the retina there.